partners in as well?
I don't think Neil's in attendance just yet. Neil booked in.
We'll hang on just a few seconds then. I think
Okay.
he won't be far away.
Here you go. He's just coming in now.
Okay. So it's 6 o'clock, so we'll start. I'll do the housekeeping first. Welcome to this virtual meeting. This is a formal council committee. The proceedings will take place live on the internet and the meeting will be recorded for future viewing. It will assist the conduct of the business if participants speak when they're invited. Members of the public are welcome to view the proceedings but should not make contributions at this meeting. All participants should mute their microphones and turn off their video feed when they are not speaking. Please remember to unmute your microphone and switch on your video feed when it is your turn to speak. Speak clearly and slowly into the microphone. Anyone wishing to speak should indicate using the raise your hand button on the Microsoft Teams, and I will invite people to speak at the appropriate time. If you do not have a hand button, please type your request to speak in the chat function, and I'm sure Helen will pick that up if I don't. I ask for everyone's patience with the use of the technology, and I apologise in advance if we experience any unforeseen difficulties, which we will try to resolve expediently. I shall now follow the items of business as set out in the agenda. Having said that, folks, I'm going to change the agenda slightly, if that's okay. First of all, we'll say, are there any apologies for absence, Helen?
None received, Chair.
And therefore, no substitutes? Are there any declarations of interest under the Members' Code of Conduct?
Just Steve Walthour here, Chair. Just the usual one that I'm the council nominee on the Council of Governors at Dudley Group of Hospitals.
Thank you, Steve. I thought it was right that during the COVID pandemic, and having seen Val's appearance on social media, which went down well, it'd be appropriate for Val to give us an update as far as today's concerned about the response from Dudley and any other details he wants to share with us. And I've said we'll do this at the start of every COVID scrutiny meeting, if that's okay with members. So Val, over to you, please.
Thank you, Chair. I've just prior to this meeting, I've sent out an update to all members so that they are aware of the growing sort of rise of cases within the borough. So just want to use this opportunity to remind everyone that the cases are rising locally as well as regionally. And although we remain one of the lowest in the Black Country Birmingham area, we are seeing quite a rapid increase, and we are now starting to see an impact on our healthcare services as well, who are already sort of saturated in terms of managing the usual healthcare that our communities gain access from the NH4. So really an opportunity to remind people that we just can't be complacent, and for members to actually support us in the messaging. We have undertaken a number of things over the last few weeks to really sort of try and put in place a focus on prevention and preventing further sort of escalation of cases. We've started to amplify key messages, and we are targeting those public health messages to some of our wards where we're starting to see a slightly higher rise in cases. I have to say they're not very big numbers. So when we say that we're seeing cases in particular wards, on the whole, our cases are still very peppered across Dudley. But what we're seeing now is possibly like 10, 15 cases in a ward in a 7-day period. And in the scheme of things, though that might seem very small, they can quickly increase to double or triple that. We've seen that happen in other areas. I just want to thank everyone for all the work they're doing in terms of identifying when when they do become a case, and that they are taking rapid action to self-isolate and contact the test and trace service and seek a test. And I do know that there is major issues with accessing tests at the moment, but that has been escalated through various channels and both between in terms of local authority, but Public Health England, Department of Health and Social Care, and NHS colleagues. We are working really hard to rapidly contain and control outbreaks, and we're working very closely with businesses and local restaurants and community facilities to make sure they are COVID secure. We have managed to secure extra staff, environmental health officers to support us in this, and if we need to, we will use legal powers, but at the moment we have had cooperation from all parties in the borough. Work continues with our COVID engagement board and members to make sure that we are ensuring that local community volunteers and local community organisations are actually on the front line and helping support our messaging. We know that that's really important from the learning from other areas where there has been high spikes and where they have had to be part of the government intervention. We have also shared a members toolkit, which should make it a lot easier for members to navigate the whole raft of guidance that is continuously changing. And I would really welcome feedback on that and how we can continue to improve that. And then finally, but most importantly, what we have to remember is that although cases at the moment are higher in a much younger population compared to what we saw at the onset of the pandemic, it is really important that we don't forget our vulnerable communities and population. We are doing everything we can to protect that group. We've stopped visits to care home. We've stopped visits to care homes, and we are putting in place risk assessments for those that require visiting for very exceptional purposes. We have also stepped up the enhanced support that was put in place right at the onset, and which actually helped keep 60% of our care homes COVID free. And we are also amplifying messages alongside with NHS partners and GPs on to our clinically vulnerable population. Again, you know, although at the moment people are probably not recognising that this is having an impact on our vulnerable, I think we are very conscious that you know, that is the group that we that all of this effort is going in to protect. So I think that's all I want to say, but I just want to thank everybody for their support and the support that we've continued to have from across the partnership in dealing with the response to date.
Thank you, Val. That's all very reassuring, and I know that we as local authority councillors, we get in pages and pages and pages of information and data and advice from yourselves, from the health partners, and also CAPA are leading the way in making sure everyone within this envelope is informed as well. So thanks very much on everyone's behalf, and you can relax now. All right. Thank you. On to the next agenda item. If it's okay with members, I've moved up the two papers that should have been submitted for information only, and move them up next because Matt Bowsher will need to leave the meeting shortly. And the first paper is Violence Prevention Strategy, and followed by the Transforming Care, the Progress and Risks. These are for information only. If members have a burning desire to ask a question, please do so. But I think Kathy Baton would like to say something along the papers anyway. Is there any member who wishes to pass any comment on the two papers submitted?
We have two hands raised, Chair. We've got Councillor Baton and also Councillor Miller requesting to speak.
Councillor Peter Miller, can I come to you first, please?
Okay, thanks, sir. Yeah, on the violence, I think one thing we do forget is violence against men. We only think it's on women, but it is also men. And I think we need to be very aware of that.
Thank you, Peter.
Take it seriously, because it tends to be considered a bit of a joke. And I know as somebody who did get knocked about by his wife, and it was treated as a bit of fun, whereas it isn't. It's virtually as sort of serious as anybody who attacks a woman, to be honest.
Okay, thank you. Sue Haywood.
Thank you, Councillor Tyler. Could I just respond to Councillor Miller's comments? Obviously, we do look at violence prevention across the life course and across all genders, and certainly in respect of domestic violence and abuse. The Commission services in the borough are for both male and female victims. So, but maybe we need to do a bit more work around the issue of gender, and I'll certainly take that back to the violence prevention group who are meeting next week.
Thank you, Sue. Kathy Baton, you're next.
Thanks, Chair. I think just on that issue, if I can just say so, Sue, I think it's about all domestic violence, isn't it? Whether it's same-sex relationship, whether it's male against female, female against male. The issue is about the provision of services and the availability of services for any domestic violence situation. But really, the point I wanted to make about the two papers was I think both of them are very, very important documents in their own right. Certainly the Transforming Care one threw up some questions for me around sustainability, and the strategy to prevent violence. There are a number of questions I've got on that. So my request is actually that we take these as papers in their own right, and we do them in a little bit more detail to really do them justice. I don't think we can gloss over either, and I think it would be fair to see if we can schedule them for early next year, Chair.
Thank you, Kathy. Any of the officers wish to come in on Kathy's comment about the suggestion? Matt, I think Matt Boucher, you raised your hand first, I think.
Yeah, thanks, Chair. Councillor Bates is quite right. They're both very serious topics. Violence prevention is one of the key features of the safeguarding strategy. Transforming care is a major driver of change and has a big impact on people with learning disabilities. You'll recall when we went to agenda setting, because of the impact of COVID, we've rightly prioritised that for now. If Councillor Bates and the rest of the committee are minded to consider the papers in more detail later in the municipal year, that's no problem at all. We'll reschedule it with Democratic Services, Chair.
Thank you, Matt. Sue Haywood again, please.
Thanks, Councillor Tyler. Just really echoing what Matt said, Cameron and I would be happy to prepare a report for later in the Scrutiny Committee's year, and by then we should have an action plan in place as well to support the delivery of the strategy. So I'm more than happy to bring a report back later in the municipal year.
Thank you, Sue. Samtok, you've got your hand up.
Yes, I was just going to say, Chair, I would absolutely agree with the comments made earlier by the elected member on a detailed discussion on sustainability of the agenda, because I think in the paper that's one of the issues that is raised in terms of long-term sustainability and the pressures that are landing with social care. So I think a detailed conversation is probably well due.
Thank you, Samtok. So are members, are there any more comments from members? No, any more comments from officers? If members are minded, then we'll ask that detailed papers on the two subjects be brought forward. It'll have to be after the new year now, so if we can timetable that in, please, Helen.
Yeah, no problem, Chair.
Thank you. That's agreed then. Thank you very much for that short but important conversation on those two crucial documents there. Moving on to agenda item 4 now. Dudley Integrated Care Provider, the ICB update on regulatory processes and contract mobilisation, pages 1 to 11. Neil Buckton, over to you.
Thank you, Chairman. We agreed some time ago that at certain stages in the process for the implementation of the integrated care provider and the mobilisation of its contract, we'd come to this committee and explain to you where we got to as part of a local assurance process as much as anything else. I'll be talking about the kind of wider assurance process that we have to go through as part of this discussion this evening. But the reason why Bal and myself were originally asked to bring reports to you was to provide some local assurance in terms of the work that we've been doing. The report that you've got this evening, I quite deliberately went into a lot of the background behind the development of the integrated care provider, because I'm conscious that not everybody sort of eats and drinks this as much as myself and other colleagues in the CCG and in the Integrated Health and Care NHS Trust itself does. And I'm pleased that Harry Turner, the chair, and Paula Cinder, the chief executive, have joined the meeting this evening, as has Dr. Ruth Edwards, the chair of the CCG itself. So I'd like to just touch on three main issues, if I may. First of all, issues around the process and the background. Secondly, just sort of bring you up to date on where the organisation is at this point in time. And then finally, to explain the process that we've now got to go through before we have the full mobilisation of the integrated care provider contract from the 1st of April next year. You'll notice that we've moved away from using the term MCP, multi-specialty community provider, to ICP, integrated care provider. That was as a result of some work that took place nationally and a review of the whole New Care Models programme that was undertaken by the Health Select Committee over 2 years ago now, when Paul Mobach, as Chief Officer of the CCG at the time, gave evidence, and the national team revamped the contract that we're proposing to use and renamed it the Integrated Care Provider Contract. So that's the reason why you may be wondering why we've moved from MCP to ICP, but that's the reason behind that. So a little bit of a reminder as to exactly why we're doing this in the first place, I guess. The reason why jointly with yourselves we decided to enter into this process some time ago was a recognition that we need to respond to the growing needs of an elderly population, and how those needs manifest themselves both in terms of the health system and the social care system. And we know that we're dealing in effect with increased demand created by a growing elderly population, and we need a mechanism for better managing that demand and also improving the health status of our population. And so that's why we focused on the three particular themes that are shown in the report: the themes of access, continuity, and coordination. So access in terms of having more timely access to services for people in order to deal with issues of demand. Continuity in terms of managing continuity of care, particularly for people who've got long-term conditions. And then finally, better coordination of services for people who've got not just physical health care needs, but also mental health care needs, social care needs, and needs that sometimes require the intervention of organisations beyond our respective sectors in the voluntary sector. So our integrated model of care is designed to function along those three lines: improve access, improve continuity of care, and improve coordination of care. And that's why it was constructed in a way that brings together a range of services, both physical health services, mental health services, voluntary sector services, predominantly what we would describe as out-of-hospital services, to respond to those sorts of demands. You'll note that adult social care services aren't included within the model, but there is we've described in the report the mechanism by which those services might be included over time. Nevertheless, we are working to try and make sure that there's close alignment between what the ICP does and how it works alongside social care colleagues and social care services. The critical element of the model, of course, though, from a council perspective, is the inclusion of a range of Public Health Commission services. So lifestyles, a number of lifestyle services, children's services, sexual health, substance misuse, and so on. And you'll see them described there in the report. The other key feature is how this operates alongside primary care. One of the issues that we are concerned about is the extent to which demand in the system creates more pressure on primary care, and how we maintain the resilience of our primary care system. So the model of care is designed to integrate primary care with all these other services in quite a unique way that hasn't been seen in the NHS previously. And our success in getting support from primary care for this particular model is something that we're quite proud about. So as you may well recall, we decided going back probably 3 years now that we would launch a procurement exercise. We went through a procurement process. We did that jointly. We assessed the bid jointly. We had input from colleagues both in public health and adult social care in terms of the process that we had to go through to assess the bid. And it's now 2 years since since both the council cabinet and the CCG governing body went through the process to agree to award a contract. We've now got an organisation in place that should be able to hold that contract. That's Dudley Integrated Health and Care NHS Trust. That came into being as an established organisation on the 1st of April this year. It holds a limited contract at the moment. It doesn't hold the full integrated care provider contract, but it holds a limited contract for the provision of 2 particular services. That's psychological therapies and primary mental health care services, so 2 mental health services. And then during the current COVID period, it's also been responsible for running our primary care Red Centre. And the organisation is currently gearing up to take on full contract from the 1st of April next year. And as a step in that process, from the 1st of October, it will take on responsibility for some further services under the terms of its existing contract. So those services are a number of services currently provided by primary care, what we call local improvement schemes. And it will also be responsible for providing what we describe as primary medical services for one of the local practices in Dudley whose contract has come to an end. That's the High Oak practice. So it will take on responsibility for delivering those 2 further services from the 1st of October this year, been through a process with NHS England and NHS Improvement to be able to do that. And in addition, we'll be transferring a number of CCG employees to the organisation as well. One thing to remember in terms of the ICP, which I keep stressing to colleagues, is that this is a unique organisation in many respects. It's not a traditional provider of healthcare in the way that other organisations provide healthcare in our system. It also has to carry out a number of activities, if it's to do its job properly, that historically would have been carried out by the CCG. So we are transferring staff to the organisation to enable it to do that. And those staff will transfer on the 1st of October as well. So that's quite a further significant milestone for the organisation. We've got another 2 significant milestones coming up this month as well. We now need to go into the next phase of the regulatory approval process, and that takes 2 forms. Firstly, the CCG has got to go through what's called the Integrated Support and Assurance process, which is a process designed to make sure that we've conducted the procurement appropriately. I think in the report I've described the different stages in that process. So we will be submitting documentation in conjunction with the ICP at the end of this month to start that particular process. And then alongside that, the ICP has got to go through what's called a transaction review, which is designed to assess whether the organisation is capable of holding the contract that we want to award to it. So again, all that documentation will be submitted to our regulators, NHS England and NHS Improvement, at the end of this month. And the process is a 3-month process. We expect to get through that by Christmas. And then at the beginning of next year, we'll start to finalise the next stages to mobilise the contract. So There's one final part of the integrated support and assurance process that we have to go through. That's just designed to make sure that we've got all the contracts in place properly, and then the full contract will start on the 1st of April next year. And at that point, the organisation will be responsible for all the Public Health Commission services that are described in the report that I mentioned earlier. I think so. We're at quite a critical stage in the process now, Chairman. You know, there's a lot of work and a lot of effort that's gone in to get this far across both our organisations. We're reasonably confident that we can meet all our deadlines, and we'll be reporting back to you when we get to the next stage in the process, as I say, which I think will be after Christmas. So I think I'll leave my comments there for the time being, and obviously happy to take questions.
Thank you, Neil. I'll open it now to members of the committee. Councillor Elaine Taylor first. Before you start, can all members, when they refer to the paper, can they nominate the paragraph they're talking about first, please?
Thank you, Chair. It's just a question on, and I'm not sure if it's relevant right at this point. Will the ICP, because I have difficulty sometimes understanding all of these papers, will it cover the GP provision? Will GP provision be part of this this ongoing ICP? And at this point now, when can we, as residents of the borough, expect our GP services to resume full appointment services, face-to-face appointment services? We're supposed to be looking after our elderly and vulnerable members of our community, and I speak to so many of these people that are so worried that they just do not, they don't do IT. So how on earth are they supposed to be part of this our provision? So that's one of the questions there. The next one that I have is how much impact is the COVID situation we're in having on this ICP? Has it pushed it back even further? And are you sure that you can deliver by April next year? Those are my concerns.
Okay.
Thank you, Elaine. Over to you, Neil.
Okay. What I am going to do is ask my colleague Dr. Ruth Edwards to deal with the issue about face-to-face access to primary care and so on, if I may. But if I could deal with the first issue and the third issue. So if you look at paragraph 16 on page 4 of the report, it describes there how GP services function in relation to the ICP. And so general practices, the ICP is commissioned to deliver GP services, but there's then a contractual mechanism in terms of how that works. So in effect, if you're a general practice and you hold a contract with the CCG at the moment, you've got two options. You can decide to either become fully integrated with the ICP, in which case you relinquish your existing contract with the CCG and you become part and parcel of the ICP, and the CCG contracts directly with the ICP for the provision of what we call primary medical services for the patients of that practice. So that's one model. The alternative is that you don't relinquish your existing contract with the CCG. You retain that contract with the CCG, but you sign up to what's called an integration agreement with the ICP that sets out the basis on which you're going to work in conjunction with the ICP to deliver a set of services and integrate more closely with other services that operate. So in essence, yes, the ICP is commissioned to provide primary care. It then just depends the basis on which individual general practices decide to exercise their option for integration with the ICP, whether they do that on a fully integrated basis or a partially integrated basis. In terms of the COVID issue, yes, and colleagues from the ICP can probably talk about that better than I can. But at the outset, we agreed to put a lot of things on hold. We would have submitted all the documentation that I described earlier for the regulatory processes a lot earlier if COVID hadn't come along. So in the period since the 1st of April, colleagues in the ICP, as well as trying to maintain some of the work that's required to meet all our regulatory requirements, have also been actively involved in the response to COVID. And I mentioned the work that they've done in terms of running the Red Centre, and also work that they've done in terms of supporting care homes, avoiding unnecessary admissions to care homes, and so on and so forth. And I think there are two key elements of this now for me personally. Yes, we need to get this model of care up and running as quickly as possible, because what this period has demonstrated to us is that if we're to maintain a safe system, then we need the integrated service model that we're looking to commission, because that's the sort of service model that's going to provide support for care homes. It's going to prevent unnecessary admissions to secondary care. It's going to make sure that our primary care system remains resilient during a time of real strain. But also, as we know, one of the things that we've learned during this period is that a lot of the health inequalities that this model of care is designed to address have become much more evident. And if we don't get this up and running rapidly, then the sort of inequalities that we're aware of now will just be exacerbated. So from our perspective, whilst we recognise the need to put things on hold in order to support the system to respond to COVID, our view now is that we need to get this in place in order to better respond to COVID in the future. And I think, Chair, Dr. Edwards is probably best placed to respond to the question about the availability of face-to-face appointments in primary care and so on.
Okay, Neil, just to come back on the one point, fully integrated, I recall that all but one GP's practice was fully integrated at this point.
No, that's not quite correct, Chair. What we've got at the moment, I think, if I get my numbers correct, we've got 43 practices in Dudley. 41 of those 43 practices are intending to sign an integration agreement and be partially integrated. And that would leave 2 practices who wouldn't have a direct relationship with the ICP.
Okay, all right. Dr. Edwards, please.
Yes, thank you, Chair. I'm happy to come in and answer that question. But just by way of introduction, yes, I'm a GP in Brierley Hill. I work at AW Surgeries and have done for a good 24 years. And I've been chair of the CCG just since July, having taken over from David Hegarty. But have worked for the CCG for about 9 years, so I am fairly familiar with the patch and the system in Dudley. So thank you for the question, Councillor Taylor. General practice is very much open in Dudley. It feels different. It feels different for us, and it will feel different for you as patients. But it is very much open. But we are triaging all requests for appointments, and all practices are doing this. And it is a national directive that we triage all appointment requests. So most practices are doing that via phone, because we very much wanted to move away from patients coming and standing at the desk and putting themselves at risk of infection, plus staff at risk of infection. So all appointments are taken by phone, and a small number of practices are also moving to using digital technology and are using an electronic platform, but not exclusively. There's no practice exclusively using that. So the ones that are using it will all still accept a request by phone, but will perhaps help a patient put the information onto the form so that they can all be looked at by a senior GP and prioritised. There is a huge demand on general practice at the moment. There was even before COVID, and then actually it went a little quieter during the peak because I don't think people wanted to cause unnecessary work and wanted to protect the system. But we are very busy again now. The whole of the NHS is very busy at the moment, and that's partly anxiety around the new peak of, or not peak of infections, but the rise of infections. But also I think there probably is some backlog of work from the spring and the summer. So it is key that we prioritise appointments correctly. The other thing is we do have to work in a socially distanced way, as all organisations have to, and all employers are having to find ways of keeping their premises COVID secure. And we have to recognise that general practice buildings are small buildings generally. So once you've got 4 patients in your waiting room, you can't really fit any more than that in. So that's why patients will have a face-to-face if felt to be clinically needed. So we do the phone call, decide whether someone needs to be seen face-to-face. If they do need to be seen face-to-face, they're given a very specific time to come up. They might even be advised to wait in a car so that they can just come straight into the consulting room. The patients need to wear masks. The staff are all wearing masks. The GPs and nurses are all wearing PPE. But yeah, we're having to keep the waiting rooms so they don't get busy, and keeping things very carefully timed. But there may be a perceived perception that primary care is closed in that the doors are not opening quite the same way, but it is very much up and running. So I'm happy to pause there and see what further questions come my way.
Chair, can I come back in, please?
Chair, you're on mute, sorry.
Carry on, Elaine, please.
Ruth, Dr. Ruth, thank you, and thank you for everything that's been said there. And I do understand where we are on this, but you know, we've got so many elderly residents and vulnerable residents that are still slipping through this system. We're almost we're well into autumn now. The flu jab provision is going to put even more strain on this, and I can't see anything how we're going to sustain the system. It's so worrying. I get calls from residents and they are so worried that, you know, they feel that they need to see a doctor. They phone the doctors and they're triaged by a young lady or a young gentleman on the desk who has no medical training at all, and they're being asked to tell them, so these are people that have got telephones even, they're being asked to tell them things that they shouldn't be asked to tell them, and they're worried about this. So I do understand where you're coming from, and I don't know what the answer is, but we certainly, there's still a lot of work to do there, is there not? You know.
Yeah, thank you, Elaine. Councillor, I've got a couple of councillors and then 2 members of the ICP. Thank you, Dr. Edwards, for that. This is about the COVID response, but of course, as a GP, you're caught in the crosshairs, unfortunately.
Yeah, that's fine.
But that's life.
Yeah, we understand. We do.
If I can take the 2 councillors first, because they may have questions that members of the ICP would want to tap into later. Councillor Jackie Cowell, please.
Yeah, thanks, Chair. I've got 2 questions basically. The first one is related to paragraph 10 on page 3, and it references the possible inclusion at a later date of adult social care and the phasing in of that. But it also suggests that one of the criteria will be an adaptation to decreasing resources over the contract period. And I just wondered whether that involves also an expectation of decreasing services. And if that's not the case, how would that be envisaged? So that's the first one. And the second one relates to paragraphs 37, 38 and 39 really. And it's around the procurement process. I just wondered how many bidders actually went into the competitive dialogue. And because there's reference to one particular bidder, which I think was the one that we ended up getting the contracts, or at least going further forward in terms of putting in the final tender. But I just wondered whether there were any more competitors, if you like, in the competitive process, and in that sense how competitive it actually was. Thank you.
Sorry, Neil. Yes, over to you.
Okay, thank you. In terms of the criteria that are laid out there for the inclusion of social care services, those criteria were drawn up some time ago, and I suspect colleagues in the council might want to review them at some point to make sure that they're still appropriate. But in terms of the specific issue that you've identified, I think Matt Boucher would probably need to comment on that rather than myself. I don't think it would be appropriate for me to comment on that, and I'm not sure that Matt is still with us now. But I think that's really something that Matt can comment on.
No, Matt's left the meeting.
Yeah.
All right, so we'll get an answer to you, Jackie, on that.
Oh, thank you. Yeah.
In terms of the competitive dialogue, the answer to this goes back to the issue that we talked about a few moments ago in terms of partial and full integration. One of our criteria for bidders was that they needed to demonstrate that they got the confidence of local general practice to deliver a model of care that was integrated with general practice. And so at what we call the PQQ stage, the pre-qualification stage, bidders were asked to indicate what degree of support they had, and we had a cut-off. And I can't quite remember now, but I think we're expecting them to demonstrate that they got the support of something like 70% of local practices. So we did have more than one bid, but only one bid met that pre-qualification criteria and was able to proceed to the next stage. So when we got to the competitive dialogue stage, we were only dialoguing with one bidder, and that bidder, as I say, had achieved the necessary threshold in terms of support from general practice to deliver an integrated care model.
Thank you, Neil. Jackie,
Thank
does
you.
that answer your questions?
Yes, thank you.
Thanks very much. Councillor Cathy Baton next, please.
Thanks, Chair. So I've got a number of questions on the report itself. So page 5, number 24, where it says that to meet in meeting the contracted outcomes framework, the ICP has the potential within 5 years to increase healthy life expectancy by 1.38 years. And I suppose the issue I have around this is the ICP has the potential, not the ICP will achieve. So I think for me, it's about the measured outcomes. We know that we have big discrepancies in healthy life expectancy in the borough. Any improvement is welcome, but I think it's the measured outcomes that I would be interested in, and understanding how the contract works to ensure that you achieve those healthy outcomes. Page 9, number 42, second bullet point, the provision of primary care services for the High Oak practice population. What will that look like? Because we know that the current facility has been given over to I think it was given over to COVID use. But I would hope that any High Oak practice provision doesn't go back into that building, because it really isn't fit for purpose, a couple of porta cabins. So what will that provision look like? Page 10, number 48. I'd just like a little bit more detail around that, please. So the role of children's services. For me, it's understanding where social care fits into that, in working with health, and are we talking more about health visitors or school nurses, or where, in terms of tackling the wider inequalities, it's all about the school preparedness and school readiness, and we know Dudley is very poor on school readiness. So how is that joint working going to look? I have got some more questions, more general ones, Chair, but I'm happy to come in later after other people have had an opportunity.
Thanks, Cathy. Over to you, Neil, for those funds first, please.
Okay, so I'll deal with the outcomes question. I can talk a little bit about higher. Colleagues from the ICP may want to talk about that as well. I'll make some comments about children's services. I expect Bal will want to talk about children's services also. I'm not trying to put other colleagues on the spot, but there are other. Okay, so in terms of the outcomes, essentially the way in which it's designed to work is that 10% of the contract value is linked to the delivery of a set of outcomes, and we've done some analysis which demonstrates that if the providers in the system, or if the system operates as its existing level of performance, then at least 95% of that element will be achieved. We've looked at the achievability. We think at least 95% will be achieved. So the level of risk associated with that from a financial perspective it is reduced. But what we're trying to do is put a little bit of stretch into the system and recognise that that we do need to improve outcomes and reduce health inequalities, and therefore we're incentivising the ICP to achieve that over a period of time. Now, some outcomes you can deliver over a relatively short time scale. Other outcomes need a longer time frame. So healthy life expectancy and the reduction of some significant health inequalities require a longer time frame to achieve. And that's one of the reasons why the ICP is going to have a 10-year contract to give them the time and the space to make all the necessary changes that are going to deliver a set of outcomes and reduce inequalities. So again, the way in which what we call the outcomes framework is set up is that some elements of it are developmental, and so the ICP has more time to deliver on the developmental aspects of it in terms of getting systems and processes and relationships right, and other aspects are more immediate in terms of how they are delivering better quality care for diabetics or patients with respiratory disease. But fundamentally, the contract is designed to incentivise the organisation to deliver better outcomes, to reduce health inequalities, but it's also set it up in a way that we think is achievable, rather than setting up the organisation to fail in the first place. Other colleagues to be perfectly honest, other colleagues in the CCG are better able to take you through all the technicalities of that than I can, and explain the evidence base behind it, the metrics that we're using, and so on and so forth. But it was a piece of work that was developed in conjunction with clinical colleagues. We did a lot of work with colleagues in public health on it. We also took external advice from organisations that have done a lot of work around contracts that are designed to improve outcomes and that contain that sort of incentivised element. But for us, it is a fairly fundamental part of the contract. And we should also bear in mind that at the moment, our GPs are already commissioned to improve outcomes. They have what used to be what nationally is called the Quality and Outcomes Framework, and we've adapted that locally, and we have now our own sort of Dudley Outcomes Framework. So the philosophy and the thinking behind it isn't something that's necessarily new to people in the system. But what we're trying to do now is make sure the entire system is working on a consistent basis to deliver a set of outcomes.
Could I just come back in before you say anything else, Neil? Can I just come back in on that? So just playing devil's advocate a little bit on this. If So an outcomes framework will give us presumably deliverables. It will give us outcomes when and how they will be measured.
Yeah.
Your contract is for 10 years. If it becomes apparent that there are areas that are not being delivered upon, what happens at that point?
Well, there's a series of stages across the course of that 10 years. But the mechanism in the contract is that, for argument's sake, say an outcome isn't achieved, and that outcome, the failure to achieve that outcome, is equivalent to a payment of £20,000. What we'd then do is we'd say to the ICP, we need you to come up with a plan as to how you're going to meet that outcome. When they produce the plan and we're happy with the plan, they would get 50% of that £20,000 back, so they get £10,000 back. And then once they've implemented the plan, they get the rest of the payment back. So what we're trying to do throughout the process is build in appropriate checks and balances and carrots to ensure that they're performing at the highest level. I think the other thing to point out is, again, one of the things we've been doing a session today with staff about the restructuring of the CCG and what that's going to mean for them in the future, and what that means in terms of the relationship that they're going to have with a integrated care provider. And one of the points I've been trying to make is that this organisation isn't going to be a healthcare provider in the traditional sense. It's not going to be like any other healthcare provider that exists in our local system or elsewhere, in the sense that it's got to not only provide services, but provide services by managing within what we describe as the whole population budget, which I think I've referred to in the report. Now, traditionally, commissioning and contracting and provision has been a very almost sort of adversarial process where we almost try and catch each other out. It's a very transactional process. The issue that we've got now is that the ICP needs to live within its whole population budget and deliver on a set of outcomes. And the CCG and the council have got a common interest in making sure that it achieves on that. We're not trying to catch them out. We want them to be successful. So we've got to work very closely together with them in terms of delivering on that. And that's why in future, staff within the CCG and staff within the ICP will have a collective interest in making sure that those common objectives are met. And we'll be trying to use our collective expertise to deliver on those outcomes.
Thank you.
Okay. The other question, Neil?
So High Oak, yes. So the ICP, in effect, the contract that's currently held by the High Oak practice expires at the end of this month. The ICP then becomes responsible for that contract. And as Councillor Baton indicated, at the moment, the services for that practice population are being delivered from Briley Hill Health and Social Care Centre, whilst the High Oak building is being used as our Red Centre. And I know there are a number of issues bound up in this, but I know that at the moment, colleagues within the ICP are looking at where they might be able to re-provide High Oak service, the High Oak practice locally in the kind of Pensnet area, and they're talking to various people about that. And then from a wider perspective, yes, the estate isn't what we want it to be, and again, colleagues within the ICP will be building that into their overall sort of primary care premises development sort of strategy for the future. But they may well want to comment on that. And then finally, children's services. Yes, we're talking here about, in effect, children's health services. So services that the CCG commissions at the moment, which are mainly sort of therapies, physiotherapy, specialist health services for children, community-based health services, and then also services that the council commissions, so health visiting, school nursing, and so forth. I think one of the opportunities that we've got is to bring those services together in a way that we haven't done before in an integrated fashion, and try and address the issues that we've mentioned in the report, around school readiness and so on. At the outset, when we first began the procurement process, I think at the time it was round about the time when council colleagues had quite a difficult CQC and Ofsted report on children's social care, and it was agreed that it would be inappropriate to include children's social care within the procurement at that point. But that's not to say that whatever services the ICP are responsible for shouldn't be working very, very closely with children's social care services and education and so on. And we're doing a lot of work at the moment on the whole special educational needs and disabilities agenda, responding to the written statement of action, and that work will continue with services within the ICP working very closely with children's social care and educational services. Now, Bal might want to add to that, because I know she's very passionate about that.
Bal, do you want to add to that? And then I'll come back to Kathy if she's got any more.
Yes, so I just wanted to reiterate that it is services that are going into the ICP. Members may be aware that due to historical and legal procurement arrangements, quite a few of our services are provided by different providers. So what this will enable us to do is develop a more fully integrated model, public health model. And as we all know, some of our outcomes in our children's population are not as good as they should be. We're not doing very well in terms of breastfeeding, healthy weight, early start, smoking, pregnancy, etc. And we know that it requires a whole system response to actually address those outcomes. So I think the other advantage of children's services, public health services being in the ICP is the returns on investment. We know actually that if we can actually give every child the best start in life and measure that through a series of outcomes across their life course, the idea is that the model will ensure that we continue to invest in the crucial public health early intervention services that will eventually go on to have an impact on the longer term outcomes in adults and healthy life expectancy.
Thank you, Bal. Kathy, I know you've got some more questions, but before I ask you to comment on what has just been said and more questions, I did have Harry Turner and Paula Cinder had your hands up, but they've vanished. I presume the questions or the points that were raised have been answered. Harry?
Yeah, thanks, Councillor. I just was going to add a little bit of texture to a couple of points, really. The question that Councillor Taylor asked around the delays that COVID introduced, just to sort of give you some context, the business case that we're going to submit on the 30th of September was due to be submitted on the 1st of April, and that was immediately after the national lockdown. So we took the decision to pause that process. And the reason behind the decision was we wanted to play our part, albeit on an informal basis, in the system response to COVID. And you've heard that we were awarded the contract for the Pensnet Respiratory Assessment Centre. What we found, though, going through supporting the system actually, was that we were gathering evidence about the value an organisation such as ours could have. And actually, although we didn't want the pause, it helped us gather evidence, which is quite useful in writing the full business case. And the question then is whether or not, the integrated care provider is still relevant post-COVID. And I can tell you that there are a number of publications, both nationally and more locally, on the response to COVID and the lessons learned and the way forward that actually completely support the development of the ICP. They're particularly around the ability for an organisation to respond to health inequalities and for an organisation to be able to integrate with GPs, community care, third sector, etc. So that was the cause of the delay. We learned a lot from it. It helped us, and we'll be incorporating those findings into the full business case that we submit at the end of September. On the issue of GPs, Neil's numbers were spot on, 41 out of 43, and the process of those being signed started. I think Paul will probably tell you that there's actually ink on paper now, and they will be enacted when the contract's awarded on the 1st of April. And that level of support from GPs is unheard of anywhere in the country. I mean, no matter who you speak to, when you tell them that level of support, it's completely unheard of. And I can tell you, although it's very, very early days, we are now starting to have some conversations about some practices, full integration. And that kind of links to the High Oak conversation, because what we need to do is demonstrate we're really good and effective at running primary care, because that will build confidence in other practices who may want to fully integrate down the road. And I can assure the committee that our estate strategy is entirely focused on delivering a good quality product in the High Oak practice. So I just wanted to add those, Councillor Tyler. Thank you.
Thank you, Harry. Paul, can I just bring you in, please, for comment, if you wish?
Yes, thank you, Chair. Just a supplementary comment around High Oak, if I may. I think sadly the COVID Red Centre will be in situ for a while yet. So our plan is to maintain that respiratory assessment facility on the High Oak site for the foreseeable future. Actually, I do agree with Councillor Baton. The accommodation in High Oak is, is pretty poor and frankly no longer fit for purpose. So we have re-provided that, or rehoused the surgery at Brierley Hill, and actually the comments from patients and service users now using the facility at Brierley Hill is really positive. And actually we've had a number of new registrations to that practice in Brierley Hill, which is something we haven't seen in the High Oak surgery previous, for quite a long time. Just in terms of the population who will have difficulty accessing services at Brierley Hill, we are going to provide an outreach service in Pensnet. Actually, we're going to use a community centre in Pensnet to provide an outreach service to local people. We're in contact with, I think there are 48 people on the practice list who are housebound. So we're in contact with them currently around servicing their needs. And we're also in contact with, I think there's 360 odd older people who previously have been sheltered, who again we are in contact with, and we're looking to provide additional services to those individuals.
Thank you. Thanks, Paul. Kathy, did you want to continue? And then I've got Steve Waltho afterwards.
Just very quickly, if you don't mind, Chair. I think that the main one for this particular item is my question around social value and investment. So a big thing for the council is that any contracts deliver social value for the Dudley Borough and Dudley residents and keep the Dudley pound local. So I suppose that the thing for me is we know that we've got a shortage, or we will have a shortage of young people or people entering the nursing career and entering caring careers. How is the contract of the ICP going to support social value in the community and getting our residents and getting young people appropriately trained?
Thank you, Neil.
Thank you, Chair. The contract itself doesn't deal with that as a specific issue, but when we put together the procurement in conjunction with council colleagues, there were specific criteria in there about the organisation's approach to social value. It was described in initially in a document we produced called the prospectus, and then it was in the actual evaluation criteria for the bid. So we did evaluate the bid on the basis of what the bidder was saying about social value at the time. I can't for the life of me remember exactly what it said, but I know that you know, and colleagues from the ICP are better able to articulate this than me, but I know that they're very keen to be almost like an employer of choice locally. In the partnership board that we're involved in, we've had discussions. We continue to have discussions about how we can develop better career pathways for young people leaving school or college who want to pursue a career in the health and care sector. It's something that we've been discussing relatively recently. So whilst it's not specifically something we're contracting for, I think it's a value that the entire local health and care system is signed up to and wants to see implemented.
Thank you, Neil. Kathy, did you want any more questions? I think you said you got some extra ones.
No, I think actually the next question I got was probably more appropriate for the next paper.
Okay, thanks. Steve Waltho.
Yeah, thanks very much, Chair. And thank you, Kathy, for commenting on social value. And also thanks for Paul's comments on the Pensnet issue. I actually live within the ward of Brockmore and Pensnet, and I have heard that many local people say that they are very concerned that they don't have a local service. So I am at least happy that there's going to be some sort of outreach provision made there. Thank you. My question really, we have another major health provider in the borough, and I am very aware that this ICP is not contractually involved with the Dudley group of hospitals, but I can only presume that they've been consulted along the way, because there is surely going to be some, I was going to say, fallout from this reorganisation, potentially more efficient, more patients moving through the service. So therefore there must be some impact somewhere on Dudley group of hospitals. Do I assume that they've been fully consulted all along the way on this, and are they happy with the way that the ICP is progressing?
Neil.
So if we go right back to the beginning, Chair, in effect, the bid that was submitted that we evaluated was a partnership bid between Dudley Group NHS Foundation Trust and what was at that time Black Country Partnerships NHS Foundation Trust and Dudley and Walsall Mental Health Partnership Trust. And in fact, another organisation was involved at the outset, Birmingham Community Services Trust, but I won't go into the details. But they withdrew at a point in time. But essentially, the bid was from what at that point were the three main local Dudley healthcare providers. So our provider of hospital and community health services, our provider of mental health services, and our provider of learning disability and children's services. And they came together in conjunction with local GPs to submit a bid as partners. And the way in which that bid was framed was that they wanted to, in effect, create an they were coming together as a partnership, and they wanted to create an organisation which would eventually hold the contract. And I think I've talked about organisational form in the report, but we went through a couple of iterations where eventually we got to a point where a separate NHS trust is going to hold the contract. And the way, again, in which the bid was framed was that organisation would have what would now be two material subcontractors. So Dudley Group NHS Foundation Trust on the one hand, and what's now Black Country Healthcare NHS Foundation Trust on the other hand. And so in that context, Dudley Group will be a subcontractor providing a number of outpatient services, and Black Country Healthcare NHS Foundation Trust would be a subcontractor providing mental health services. So throughout the process, Dudley Group NHS Foundation Trust has been very much part of the process. They were the lead bidder to begin with. They were the ones who pressed the button and submitted the bid. And they've been, as I say, they've been part of that partnership. And the role of that partnership was to create an organisation to hold the contract, and then the other two main local healthcare organisations would become subcontractors to that organisation. So yes, they're very much part of the process. I think it's fair to say, you know, we're at a point now where there have been tensions, if I can use that term, over the past few weeks, particularly now around the subcontract arrangements that have been negotiated and the impact of those on both organisations. It's probably inappropriate to go into too much detail about that because, you know, negotiations are going on at the moment. But I think we're reasonably hopeful that those issues can be resolved to everybody's satisfaction by the end of the month. The position that we then get to in terms of the local system, and this is something that we've discussed with council colleagues and other partners within our partnership board, is that we'd end up with two major local providers of healthcare. So Dudley Integrated Health and Care Trust on the one hand, responsible for, roughly speaking, half our system. The CCG's budget is round about 500 million, probably more than that now, but around about 500 million pounds. The ICP contract will be round about 250 million pounds. So that organisation providing what you might describe as out of hospital care. And then on the other hand, Dudley Group NHS Foundation Trust, responsible for what we would describe as in effect hospital care, so planned care and urgent care. And they would be operating alongside the CCG. So the CCG would hold two main contracts, one with Dudley Group NHS Foundation Trust, one with Dudley Integrated Health and Care NHS Trust. There would be subcontract arrangements between those two organisations, and the CCG will be looking to develop what we call gain and loss share arrangements between all three parties, so that we've got a system that works in balance. So the ultimate position that we're trying to get to is that nobody is disadvantaged as part of this process, that we have a system that is in balance, and that in many respects, Dudley Integrated Health and Care NHS Trust uses its capabilities to relieve a lot of the pressures that Dudley Group Foundation Trust experiences at the moment. So, you know, one of the big issues for them is inappropriate admissions for emergency care. The ICP will be incentivised to avoid inappropriate admissions for emergency care, and that will enable Dudley Group to focus on what we think it does best, which is provide urgent care and provide planned care, whilst the ICP focuses on what we think it can do best, which is integrate services around primary care, manage demand and prevent unnecessary admissions to hospital. I probably whittled on a bit there, but I hope I've managed to answer your question one way or another.
Steve, any more questions?
No, thanks very much for that, Neil. Pretty comprehensive response. I was fairly certain that DGOH was heavily involved somewhere in the system, but I didn't see it referred to at all in the paper. That's why I asked the question. Thank you.
Thank you. Are there any more councillors wish to ask any more questions on this issue? No.
Sorry,
Jane?
Chair, I've got Councillor Miller.
Jane Emery first, and then Councillor Peter Miller.
Hi, yeah, thank you. I suppose just from a Health Watch perspective, I just wanted to let members know that we've been involved in elements of the procurement process to make sure that people are involved. And also we've made some comments with regards to the business case and making sure that people remain at the heart of this new organisation, and that people can have a real opportunity to influence future services, and that, you know, the services, the buzzwords around co-production, co-design, that kind of continues. So we've put that to the Integrated Health to make sure that that's pivotal in the development of the organisation. So just wanted to give some members assurance that we have been part of that process and are requesting that to continue.
Thank you, Jane. Peter.
Okay, thank you, Chairman. There's 41 out of 43 GPs involved. What happens to the 2 who are not involved? And probably more importantly, what happens to the patients? Are they in danger of losing out if they, if their GPs don't become involved?
So the patients of the practice will still receive services provided by Dudley Integrated Health and Care NHS Trust. The main impact for the practice itself is that I mentioned earlier, almost in passing, but we've got our own local outcomes framework for general practice. Under the terms of the national GMS contract, there's what's called the National Quality and Outcomes Framework. Over the past few years, we've developed that and developed our own version, and we think our version is probably a little bit slicker than the national version. Is easier for practices to operate and so on and so forth. So, if practices don't sign the integration agreement, then they won't be able to operate in accordance with the local outcomes framework. They'll have to operate in accordance with the national outcomes framework. What we've also done is we've looked at some of the monies that we invest in primary care services, and in order to further incentivise practices in terms of the local outcomes framework, we put more resource into that local outcomes framework. So if you're not signed up to the local outcomes framework, then you won't have access to the same level of resources as the other practices. But ultimately, we'd like everybody to sign an integration agreement. We'd like every practice in Dudley to be either fully integrated or partially integrated. And we'd be encouraging the 2 remaining practices to do that if we can over the next over the next months and years.
Thank you, Neil. Anything more, Peter?
No, that's all right. Thank you.
That's fine. Any more councillors wish to add anything to this report? No. Right, my turn then. Can I just a couple of things. This is a housekeeping one, Neil. It's just for you, but it's as much for us really as a council. Acronyms. One member has mentioned to me that it would be nice to have a glossary on acronyms, because health professionals talk health language, council talks council speak, but general public speaks neither of those languages. So as much for your report and as much for our final report, we need a glossary on acronyms to go in our final report as well.
We do that, Chair.
Yeah, okay. Page 9, please, Neil. Paragraph 47. It says COVID-19 has further exposed some underlying health inequalities that exist in Dudley. And I suppose this ties in nicely with High Oak as well, because as Kathy Baton quite rightly says, 2 porter cabins on a pub car park isn't really fit for purpose for the next 2 or 3 generations. So we need to do something on that aspect of it. But how do you work out what your areas of need are? If you've got if the ICP has got the budget to provide premises and infrastructure, how do you work out your areas of need? Is it because of the ageing population? Is it because of the indices of deprivation? Because we've had this conversation last September, if you recall. There are certain areas within Dudley Borough where the ICP and all the partners could have a better effect and a better hit with a better return for their finances by locating some of the services that you go into within those indices of deprivation areas or areas of most need. It would be nice to know how you work out what your areas of most need are. And moving on to the bottom end of that paragraph, identifying those areas such as housing and employment, where the ICP needs to work in conjunction with other organisations. it occurs to me, I mean, we're going to scrutinise on the 27th of January the Health and Wellbeing Board. It occurs to me that you've already got an organisation there which is tailor-made to drive the ICP model with its housing, employment and regeneration. It's tailor-made to help on that aspect of it. But the problem we've got at the moment, the Health and Wellbeing Board, in general, seems to be a board that receives reports, lengthy, wordy reports, notes them, and then asks for an update in 6 months, 12 months' time. It has the capacity to drive progress. And our two senior health officials quite rightly said in the last meeting of the Health and Wellbeing Board that the board can actually make recommendations, but having looked at the minutes for the last 2 years, I haven't seen many recommendations coming forward. So that's another aspect of it. So there's a tailor-made organisation there to support the ICP. I'll leave it at that for now, Neil. Over to you, Neil. Sorry.
Sorry, yes, I think. Sorry, Chair. Yeah, I think there's a couple of things that we've done quite a bit of work looking at health need and demographics and so on, and yes, we have focused very much on indices of deprivation, other factors in terms of the demographics of particular areas. You know, we've done that in conjunction with colleagues in public health, and I think, you know, we've all got the responsibility from the context of the Health and Wellbeing Board to be informed by what the Joint Strategic Needs Assessment is telling us. So essentially, there's a lot of intelligence that we've got in the system one way or another that the ICP will need to use to focus its efforts on particular pockets of the population if it's going to have an impact on health inequalities and meet the requirements of the outcomes framework.
Okay. Harry, did you want to come in on that?
Yeah, thanks, Councillor Tyler. I just wanted to sort of make a couple of points, general points to members of the committee, if I may, as we come to the end of the paper. So in January, it will be 6 years that the initial bid was made for this, which was accepted with many others across the country to become what was then called multi-speciality community providers. We are the last man standing, you know, the others have fallen away. And I think it's a credit to Dudley that it's kept its resilience and kept going. And frankly, thank God they did, because the challenges that Dudley face pre-COVID, but now amplified post-COVID around health inequalities are huge. And I Councillor Tyler, you'll know when we talk, when we've spoken, I start every conversation by saying, you know, the average man in Dudley will spend 23% of his life with one or more medical condition, you know, a quarter of their life. And we're here to try and fix that. And I think it's important that we do that. But what we're doing is complex and it's innovative as well. And if I had £1 for every time I'd spoken to someone about this, about an element of it, and they said, "Oh, that's never been done before," it hasn't. You know, we are groundbreaking here, and I think everyone in Dudley should be rightly proud that we've got here. I certainly am. I couldn't be more proud that we are within touching distance of landing this and making a real difference. And you know, it'll put Dudley on the map as an innovator, and it'll also put Dudley on the map as taking seriously the health inequalities. And that to me is really, really important, and we should remain focused on that. I recognise that a number of members from this committee and from the wider council may well be new and not been on that 6-year journey, and I would just extend an invitation, I'm sure Paul will join with me, of inviting any councillor that wants to meet with myself and Paul, unfortunately virtually, and we can take them through some of the detail that we perhaps can't share in this committee, but we're very happy to do that. And Councillor Tyler, you'll know that I've already committed to you that I'll come back, as will Paul and Neil, to this committee anytime to explain what we do and where we're going. But we are now on the cusp of doing something really special, really different, and I think we should be really proud and excited of what we're about to do. Thanks, Chairman.
Thank you, Harry. And yes, it is good that the ICP has committed to having a public scrutiny meeting, so very welcome that is as well. So there's no other questions. I'd like to thank all the members of the ICP for presenting the paper, all the members for asking the questions. The recommendation is that the current position in relation to the development of the Dudley Integrated Care Provider, Dudley Integrated Health and Care NHS Trust be noted by scrutiny. Is that agreed?
Yes.
Yeah.
Thank you very much.
Yes.
Thank you. I'll take that as a yes then. Moving on to the next agenda item, number 5, the future commission in the Black Country and West Birmingham report on the CCGs. Neil, is that you again?
It is there, yes, thank you.
Thank you.
I've got some slides which I think Eleanor, colleague, was going to put up on the screen for me. There we go. Great, thanks very much. So essentially, Chair, this is about a proposal to bring together the 4 Black Country and West Birmingham CCGs into one. And if we move to the next slide, you'll see that, you know, in effect we've got 5 places within the Black Country and West Birmingham at the moment. So we count West Birmingham as a separate place alongside Sandwell, but 5 places and 4 CCGs. And we're now actively looking at a proposal to bring all those statutory bodies together in into one statutory organisation. And if we move to the next slide, you'll get a sense of the context for this. And this goes back to the NHS long-term plan that was published in January 2019, where there was an expectation that each STP, that Sustainability and Transformation Partnership, would have what was described as a single commissioning voice, so a single commissioning body serving each STP. And in this context, our STP is the Black Country and West Birmingham, as you have noted from the map earlier. So a clear sort of direction in terms of national policy to create one CCG for each STP area, and that has been amplified in recent communications from NHS England and NHS Improvement in terms of how we move towards the next stage of restoring services post-COVID, what's described as the phase 3 letters. In that letter, they talk very much again about having a single CCG for each STP or what might become an integrated care system. And I'll talk a little bit about that in terms of the next slide. So this slide's intended to sort of illustrate the 3 different levels at which we're expected to work in the future. So first of all, the ICS level, the integrated care system level. An integrated care system is the follow-on to an STP. So the vision is that each sustainability and transformation partnership will become an entire integrated care system. So that would be the Black Country and West Birmingham level. Then within each integrated care system, there would be what's described as an integrated care partnership. So just going back to the comments I was making earlier in terms of the previous item, the Dudley Integrated Care Partnership in future would consist of the CCG alongside our local authority colleagues, but with then the 2 main healthcare providers that we're going to be contracting with. So Dudley Group NHS Foundation Trust and Dudley Integrated Health and Care NHS Trust. That will be our local integrated care system. And then within that system, we would have what are called PCNs, primary care network. So in Dudley, we've got 6 of those at the moment, based around the kind of township areas that everybody will be reasonably familiar with. And they're designed to create a more sustainable primary care system. And there'll be a relationship between the PCNs and the ICP in the future, in the sense that each of the practices within each primary care network will either be fully integrated or partially integrated with the ICP, or, going back to Councillor Miller's question, not integrated at all. But that's how the population is intended to function prospectively. So an ICS with a single commissioning body, and then working at place level and working at neighbourhood level. We talked earlier about health inequalities, and the next slide kind of illustrates the health inequalities that we face across the Black Country. And as you can see, there are some differences there between the 4 places, but there are also some similarities as well. Particularly if you look at things like some of the outcomes for children, childhood obesity, also adult obesity. And I think what this illustrates is the recognition that we need to be working collectively at scale to address some of these health inequalities. And working at scale is very much something that drives the move towards having a single commissioning organisation. And on the next slide, we've tried to set out what we think the advantages are of being able to operate at a greater scale on a Black Country footprint. So firstly, an ability to exert greater leverage over our service providers, particularly our acute services, where we think there's a strong case for more collaboration and more integration across our acute services providers. An opportunity to address some of the variations that we see in terms of service provision on a wider scale. Going back to the previous slide, an opportunity to address some of the health inequalities that we've identified, in particular those that have been exposed as a result of the COVID experience. An ability to manage our finances in a more robust fashion, and then also an ability to reduce duplication and reduce management costs by having one organisation rather than 4 separate organisations. Now, on the next slide, we've described some of the progress that we've already been making in terms of moving towards this particular set of circumstances. So the 4 CCGs in the Black Country decided some time ago that they wanted to move towards a position of having a single accountable officer serving all 4 organisations. And Paul Moback, who was the Dudley accountable officer, was appointed as a Black Country and West Birmingham accountable officer in November 2019. Then a move towards having a single senior management team to serve all 4 organisations. That team is virtually all in place now. I think there's just one further appointment to make. So there's a single management team currently serving 4 separate organisations, and I'm fortunate enough to be part of that team. We've moved towards the creation of a set of governance arrangements to work across 4 organisations. So all 4 governing bodies now meet collectively, what we call a governing body meeting in common, which is quite a significant gathering. There's probably over 50 people involved in that meeting at any one time, and that's something that Dr. Edwards has been chairing in the relatively recent past. We've done a lot of work in terms of sharing learning across all 4 organisations, and during the COVID period, something that we'll be talking about at the next meeting of this committee is how all 4 organisations have worked together in terms of delivering a response to COVID. And now we're developing a single approach to how we address the whole issue of restoration, recovery and reset. So how we get services back on track at this moment, and the sort of things that we discussed earlier about primary care becoming available again and so on. So one of the things that it's worth reflecting on in this in this context is the position that we think we've got to in Dudley. And on the next slide, I've tried to describe what we think some of the strengths are in terms of how we work in Dudley at the moment. So a number of things here. So we think we've got pretty strong relationships with primary care that have enabled us to do a number of things. And I think the fact that we've got 41 out of our 43 practices prepared to sign an integration agreement and support the development of the ICP is testament to that. I talked earlier about primary care networks. We've got 6 primary care networks. They're all developing pretty rapidly, and they're providing a basis for a more sustainable model of primary care. We think we've got good relationships with other colleagues in the system, yourselves as our local council, but also voluntary sector organisations and other organisations that have an impact on the wider determinants of health and what we need to do in terms of addressing health inequalities. And we think we've embedded our partnership model of working through the development of Dudley Integrated Health and Care NHS Trust. So we talked earlier about the breadth and the reach of that organisation and the extent to which it's something that we've done in partnership with other organisations locally. So they're very much strengths that we think we can build on in terms of how we move forward in the context of a bigger commissioning organisation. There are some particular tasks that we now need to do in this context, which are shown on the next slide. So we need to make sure that we develop and sustain the Integrated Health and Care Trust. We need to make sure that it delivers on its contract and it meets all the outcome objectives that we talked about earlier. We want to continue the development of our primary care networks, make sure we've got sustainable primary care. We want to maintain all the relationships that we've got with our partners, maintain the sense of place, and continue to build on the strengths that Dudley has as a place that I mentioned on the previous slide. Share whatever learning we have with colleagues elsewhere, and take use of the advantages of operating at scale for our local population, dealing with the sort of health inequalities issues that I've already mentioned, and also trying to make sure that we get better collaboration between acute hospital services as well. So we had an engagement event around this about a month or so ago, and we've been having discussions. That was with partners and stakeholders. We've been having discussions with GP colleagues as well since then, and I think it's fair to say that a number of concerns have been raised, both from our stakeholders and our partners, but our GPs as well. And on the next few slides, we just tried to address those and deal with them fairly directly. So the next slide deals with the issue of centralisation. I think there's some concern that a single CCG for the Black Country and West Birmingham would be centralised and remote. And what we're trying to point out here is that Dudley would still very much have its own team dealing with the issues that need to be dealt with in Dudley, based in Dudley, working very much in conjunction with our local partners, and reporting to a local committee, what we describe as a Dudley Commissioning Committee, where we would deal with all the local issues that need to be dealt with at a place level. So that's the first concern. Second concern again goes back to the primary care networks that I've mentioned on a couple of the slides now. There's some concern that those might disappear. Primary care networks are very much a key element of the national, what we call the General Medical Services contract. So contractually, they're here to stay. But more importantly, from a local perspective, they're a key building block in terms of how the ICP operates alongside primary care and operates alongside practices with whom it's got an integration agreement. So nothing in this proposal would affect the primary care networks from our perspective. The next slide is in terms of how local influence and control and decision making might be lost. Well, we would still have a system whereby local GPs would be represented on the governing body of the CCG. CCGs are intended to be clinically led organisations, so that would remain. As I mentioned on the previous slide, Dudley would have its own local commissioning committee. That would be supported by myself and my team, and would include input, as we have on our local governing body at the moment, from the Director of Public Health, the Director of Adult Services. And that committee would have a key responsibility for making sure that we fulfil all the key issues, all the key responsibilities that need to be handled locally. If you look at my job description as Managing Director, I've got 3 key responsibilities. The first is managing the contract with the integrated care provider and sustaining our integrated model of care. The second is in terms of the relationship that we have with local GPs and the development of primary care networks. And the third is around making sure that we work effectively with local partners, including the council and including the voluntary sector and other organisations. And that local commissioning committee will be very much focused on those key local issues. Fourth area, and next slide, is around performance and concern that somehow our performance might drop off. I think it's fair to say that all the CCGs in the Black Country, their performance rating that's given by NHS England and NHS Improvement is good, and so there's no reason to suggest that should not continue. And whatever arrangements we have in our local place will be designed to sustain that in terms of how we fulfil those 3 main responsibilities that I talked about a few moments ago. The next issue deals specifically with the development of the Integrated Health and Care Trust. Some concern that might be lost. As I tried to illustrate in my earlier report, and as Harry has mentioned, we're very much on track to deliver this now, and all the full business case and the documentation that's required for the assurance process will be submitted at the end of this month, and the CCG will be entering into a 10-year contract with that organisation. So that organisation is certainly going to be here for quite some time to come. And then finally, some concerns about money, essentially, and some concerns that our money is going to be spent elsewhere. Well, there's a fundamental commitment that the level of expenditure that takes place within Dudley at the moment, that £500 million that I mentioned when I was talking about the local system, that will remain, both in terms of what we spend on hospital services, what we spend on primary care, and what we spend on the sort of services that we commission from voluntary sector providers as well. So hopefully we've gone some way there towards addressing some of the concerns that have been expressed, as I say, not just by the general practitioners, but also by partners as well. A key thing for us is how Dudley retains its voice within this system. As I say, Dudley would be represented on the governing body. We'd have a very strong local commissioning committee and a strong local management team as well, all focused on Dudley and all focused on the relationships that we need to sustain in Dudley. The next slide just provides an illustration of the governance arrangements. As I said, this centres very much about having a local commissioning committee, and without dwelling too much on this slide, if you just turn to the next slide, you'll see that this commissioning committee has got some fairly specific responsibilities that all relate to what needs to happen locally. So issues that hopefully you'd recognise there about how we input into the joint strategic needs assessment we talked about earlier. I work with the Health and Wellbeing Board, the management of the Better Care Fund that we have a Section 75 agreement with the council for. So all those issues are very much Dudley issues that the Dudley Commissioning Committee would retain responsibility for. So in terms of the process that we're going through at the moment, the next slide just talks about some of the timeline. We've been having a number of engagement events over the past month or so. A report will go back to what we call the transition oversight group in October. The next slide shows the kind of timeline that's involved, and ultimately this is dependent upon a vote by our general practitioners. Just to remind you, CCGs are membership-based organisations, and the members are the general practices. So it's only the GPs who can make a decision on whether or not this proceeds. If we decide to proceed to a vote, then that will take place as illustrated there in the early autumn. So finally, just to kind of summarise in terms of the key issues as we see it, we do think that being able to operate at a larger scale is going to bring a number of benefits that will serve our patients and our population. Clinical leadership has served our CCG well over the past few years, and that remains paramount. That will be sustained both in terms of how local GPs are represented on the main governing body, but also how they're represented on the commissioning committee. We think this is an opportunity for us in Dudley to focus very much on what we think the key local issues are: sustaining our primary care networks, developing the ICP, and having effective partnerships with stakeholders, including the council. And finally, this isn't about reducing resources. This is about sustaining the resources that we've got in Dudley now and developing those for the future. Thank you, Chair.
Thank you, Neil. Any questions from members of the committee? Steve Waltham.
Yes, thank you, Chair. I guess this question's more from a user point of view. The public, Jane, might be able to comment on this, being sort of consulted on this, because some economies of scale must surely, on this kind of scale, if we're going to try and lump 4 huge organisations together, I appreciate there are going to be cost savings, but will there still be the same kind of services maintained locally, or will we see some patients having to move around the Birmingham and the Black Country to receive certain speciality services?
Can you do that now, Brett?
So in terms of your first point, Councillor Wolfo, yes, as part of the engagement process, patients and the public have been invited to some of the online events that we've had. We haven't been able to conduct this in the way in which we would have done historically, but they have been invited to comment, and we've had discussion with our practice participation group and so forth. In terms of services, this proposal isn't about changing services, it's about changing the commissioning organisation. And as I've indicated, we're not talking about moving resources out of Dudley, we're talking about maintaining the current level of resource that we've got in Dudley. One of the things that we are conscious of is that by operating at a larger scale, it does give us opportunities to look at some of the things that we haven't been able to address historically, particularly in terms of how our hospital services can operate more effectively together. So we've got 4 acute hospitals in the Black Country, and our view is that if they collaborate in terms of care pathways, then there are opportunities there to reduce some of the health inequalities that we experience at the moment, and to deal with some of the variations in service that we experience at the moment. So we do see this as an opportunity to make some changes in service, but we're not talking about trying to do something that means people are going to have to travel all over the place to access services that should should really be available, you know, within their local place.
Okay, Steve, on that.
Yes, that's fine.
Okay, I've got Kathy Baton and then Ian Taylor and then Jackie Cowell, please.
Thanks, Chair. Neil, you and I have discussed this a little bit previously, but we're obviously, the two papers that are presented tonight are very significant changes in provision of, or in the way we commission and provide services within Dudley. And I just wanted to explore a bit further with you. How assured are you that the new systems that will be in place in terms of commissioning services will be reactive enough to respond to the rapidly changing demographics of our population? Now, I reference that back to the increased numbers of residents we now have within the town centres, and the discussion we had previously around the permitted residential developments and the transient nature of that group, those residents that we have. So what are the assurances that we have that the system will be responsive to those changing needs?
Well, I think that there are probably two aspects to that, and I guess they both relate to both items that we've had on the agenda this evening. So in the first instance, and they're both issues that will be handled at a local level. They're not what I would describe as black country or system-wide issues. They're very much local, place-based Dudley issues. So in the first instance, in terms of responding to the way in which population's changing, housing developments are changing, and so forth, I think that boils down very much to the way in which we manage our contract with Dudley Integrated Health and Care NHS Trust, and we have effective relationships with colleagues in the council who deal with planning and development and so on, to understand the way in which the population is changing, to understand the way in which housing provision is changing, and to make sure, in the first instance, our primary care system is responding to that, and that we're taking proper account of that in terms of how we develop primary care premises provision for the future. And that's a fairly live issue for us now, and we've already started to have some discussions with council colleagues, with fellow officers, about the way in which the town centre is going to change and the way in which we need to respond to that in terms of making sure we've got the right primary care provision and primary care premises. So in the first instance, there's the way in which we operate in terms of managing our contract with Dudley Integrated Health and Care Trust, because they're going to be the key vehicle for how we adapt and respond to those changes. And then secondly, again, that's very much a local issue. And for the point of view in which, the way in which the CCG operates in the future, then that would be an issue that the local commissioning committee would need to be focused on. It would need to be assured that that we're making all the necessary provision, working in conjunction with our partners, and working in conjunction with primary care. So again, it goes back to, in effect, the three key things in my job description. So making sure the Integrated Health and Care Trust is operating effectively, making sure that we've got effective primary care to respond to the sort of changes you describe, and then finally making sure that we're working with our local partners to respond to that as well. So I think it's very much a local issue. The assurance needs to come from the commissioning committee operating effectively, and us presenting ourselves before your scrutiny committee on a fairly regular basis, and then in terms of the way in which we manage the contract we have with the Integrated Health and Care.
Thank you, Neil. Okay, Kathy.
Yeah, thank you.
Okay, Elaine Taylor next, please.
Sorry, sorry, Chair, my mute hadn't gone off. Right, yeah, yes, Neil. My worry here is this year we're doing this. We're looking at this merger. Next year, will it be an even bigger merger? And then will Dudley certainly get lost? Because reality says the provision will inevitably operate at the bigger establishments. So I don't see how Dudley can survive in its own entity, provided for its own residents at this point, because I've seen in reality where services get put to other places and then we end up losing out again. And I haven't seen anything in here that you said that assures me that our Dudley residents are not going to be left behind.
Neil, just briefly, please.
Yes, I mean, I can only in terms of future changes, I'm not really in a position to predict what they might be. I mean, you know, at this point in time, these major changes are kind of quite enough for me, to be perfectly honest with you. So I can't really comment on what might be the next thing round the corner. But I think I just reiterate the couple of points that I've made earlier. In terms of what we're trying to do locally, we're going through a process whereby we're locking into Dudley quite a significant amount of resource. So in terms of Dudley Integrated Health and Care Trust, we're going to have a contract with them that's worth in excess of £250 million for 10 years. So that's a significant amount of service that we're going to be commissioning that's focused solely on Dudley. And you know, that's very much a driving force behind what we've done in terms of the entire procurement process, a desire on both the CCG's part and the council's part to have an organisation delivering integrated care that focuses solely on Dudley. So, you know, I think that's a pretty strong guarantee for the future. I mentioned our primary care networks. We've got 6 primary care networks, and we've got 41 local practices who are wanting to integrate with Dudley Integrated Health and Care NHS Trust. So again, that's locking in quite a significant resource for Dudley. And then after that, I think it's about how we make sure having done that, we retain, you know, a strong Dudley voice in whatever system we have, whether it's the Dudley system, a Black Country system, or a wider system. And the one guarantee around that is that it can only change if it's got the support of local general practitioners. And the proposal that we're talking about at the moment, we're reasonably hopeful it will have the support of local general practitioners. And one of the reasons why they're prepared to give it their support is that we think that we've been able to assure them that, firstly, they're going to have a pretty strong management team working with them locally to sustain what we've got at the moment, and that they're going to have a local committee, a local body that's going to take the key local decisions about local service provision respectively. So I think those are the main sort of assurances and guarantees I can try to give you. Obviously, you know, there are always unknowns with this, but I think in terms of what we're trying to do, both in terms of this initiative and in terms of the development of Dudley Integrated Health and Care NHS Trust, we're trying to make sure that there's a strong Dudley voice, and the resources that we've got in Dudley at the moment remain here and address all the issues that we've discussed earlier.
Thank you, Neil. Steve Walther, your hand's still up. Do you want to come back on something?
Sorry, Chair, mistake.
Okay, so Councillor Jackie Cowell.
Thanks, Chair. Yeah. Firstly, I had experience at the end of last year of even under the current system of having to go over to Birmingham Eye Hospital. Now, I've heard what you said obviously previously about the fact that we'll have services locally and whatever, but one thing that did strike me then, there was an issue over, they obviously couldn't see the records from Dudley. And within the scope of this particular area and those facilities that are going to be more closely allied, is there an opportunity there for the records to match up more so that where patients do need to go, is that something that would be possible in future where people can actually be referred over and they will actually be able to see the records?
Yes, well, I think again that's not an issue that is directly driven by what we're talking about here, but I think there's a commitment across the NHS to have what we describe as greater interoperability. So the system that's in operation at the Eye Hospital, or the system that's in operation at Royal Wolverhampton or at the Queen Elizabeth in Birmingham, is able to talk to other systems to make sure the right information is in the right place. I mean, that's something that we'd want to do regardless of any changes in the commissioning structure that we've got. We just think that's the right thing to do in any case. So yeah, hopefully over time the issues that you've experienced will be eliminated.
Thank you.
Thank you, Neil.
There was just one other quick question, and it was actually one of these acronyms. I can't find anybody who can tell me what it means. This QIPP.
Okay, yeah, that's forgive me. That's entirely my fault. I haven't forgot what Councillor Tyler said earlier. So that stands for quality, innovation, productivity, and prevention. And essentially, it's essentially about how we try and make things more efficient and save money.
Thank you. Okay, Jackie. Yeah. Any more councillors? Councillor Cathy Baden.
Thanks, Chair. It's just kind of struck me from Neil's presentation, the initial presentation, where you talked about having in place the new overall management structure of the organisation. What happens if the GPs don't vote in favour of it?
Well, we're already, the four organisations are already committed to having a single management structure. So, and we're in the process now of, as I think I mentioned earlier, we've now the senior leadership team is more or less in place. This week we started consultation with staff about what the rest of the management structure looks like. So, regardless of whatever vote is taken by the GPs, there will still be a single management structure serving four separate statutory bodies. The issue from our perspective at the moment, as much as anything else, is it's a little bit clunky serving four separate statutory bodies. So from a management perspective, serving one statutory body would make life a lot easier. There are some wider implications to this, which I will mention in terms of what might happen if there's a no vote. If there is a no vote, then potentially it opens up a number of questions about where West Birmingham might sit in future, and whether West Birmingham should be part of Birmingham and Solihull. Now, obviously, it's not part of Birmingham and Solihull at the moment. It's very much part of the Black Country and West Birmingham, but that question would be opened up. And if West Birmingham were to become part of Birmingham and Solihull, then that would then have an impact on our management structure. It would reduce the amount of resource we've got available for our management structure, and potentially create all kinds of difficulties and uncertainty for staff and so on. So, as speaking as a manager, then having a yes vote is going to lead to greater certainty for the staff I'm responsible for than a no vote would, because it would open up a whole series of questions about what the organisation should look like in future. But we're not there yet, but it is a potential issue for us.
Thank you, Neil. Any more questions from any more councillors? No? I've just got one, please, Neil. If you go to your slide 5 on the concerns list, the STP is committed to each place having an integrated care model. Now, we know that Dudley's has taken 5 years to be born, and it's a one-off. At what stage of the care package of the integrated care models in the other 3 areas? And is there capacity, or will there be a drive if ours is a success and the others aren't, or vice versa, for one integrated care package model to cover the 4 CCGs?
Okay, I think so. The other places, they've all been developing their own integrated care model, and they're all slightly different. The factor that makes ours stand out is that we're talking about a separate new organisation. The others aren't talking about creating a single organisation. So they will continue to develop, and some of them are at more advanced stages of maturity than others. What the long-term plan does talk about is how they want to use the learning from the Vanguard programme, which we were part of, to further develop integrated models of care. So it may well be that the other areas move along the same path as we've done. There are certain issues that would need to be addressed to be able to get to the point that we have, not least the issue around organisational form. Now, we've been quite fortunate in many respects in that we've been able to establish a separate organisation on the back of what happened in April when Black Country Partnerships merged with Dudley and Walsall Mental Health Partnership Trust. To be able to replicate that in the other areas would require legislation. So it may be that ultimately they all move in that direction and have an organisation, but as I say, it would require legislation. So they'll probably continue in terms of developing what they're doing at the moment and seeing how far they can get. In terms of having a single organisation for the entire Black Country, for me that contradicts the whole notion of having an organisation that's focused on place. And going back to what I was saying not too long ago, one of the driving factors behind this, particularly for yourselves in the council, but also for the CCG, is we wanted an organisation that was focused on Dudley and nowhere else. And so I think we'd probably have some misgivings about moving towards a position where you had an organisation that was focused on the entire Black Country rather than just Dudley as a place.
Okay, thank you, Neil. It's just that it just crossed my mind that what happens if the other 3 fall over? But there we go. Are there any more questions from any more councillors? Are there any more officers who want to add anything to the discussion tonight? Everybody wants to go home. Everybody wants to go home, right? So the recommendation, members, is that the position in relation to the development of a single CCG for the Black Country and West Birmingham be noted, and that a further report be considered in due course. Is that agreed?
Agreed.
Yeah.
Thank you very much.
Chair.
Agreed, yeah.
Sixth and final agenda item, to consider any questions from members to the chair where 2 clear days notice have been given to the monitoring officer under Council Procedure Rule 11.8.
None, Chair.
Thank you very much. Thanks very much, ladies and gentlemen. That's been a good meeting, I think. And good night. Thank you.
Thank you.
Thank you.
Thank you, Chair. Good night.
Thank you, Chair. Thank you, everyone.
Good night.
Good night.
Thank you, Chair. Good night.
Thanks, Chris.